Hi, I am Ayshath Shaniba, Tutor cum Anaesthesia and OT Technologies, Department of Anaesthesia and OT Technology, Yenepoya School of Allied Health Science, Yenepoya deemed to be University. Today I am here to present the topic double lumen tube. At the end of the session, the audience will be able to explain about what is double lumen tube, its part, differentiate various type of double lumen tube, explain proper insertion technique of double lumen tube, and can be list out the complications and contraindications of double lumen tube. Introduction. The development of double lumen tube between 1950s and 1960s was a response to fast growing capabilities in thoracic surgery. Carlen's DLT full length surgery in 1950 was a landmark in the development of thoracic anesthesia. Now we are moving to the definition of double lumen tube. The double lumen tube is a type of endotracheal tube which is used during thoracic surgery and other medical condition to achieve selective, one-sided ventilation of either right or left lung. Now we are moving to the parts of double lumen tube. As shown in the figure, there are two lumens in the top, tracheal lumen and bronchial lumen. Tracheal lumen is used to ventilate the non-isolated lung, and the bronchial lumen is used to ventilate the lung where the bronchial cuff is placed. Then the pilot balloons. There are two pilot balloons, bronchial pilot balloon and tracheal pilot balloon. It is used to inflate and monitor the cuff pressure. Now we have tracheal cuff and bronchial cuff. Tracheal cuff is inflate to seal the trachea and bronchial cuff is inflate to seal the bronchus. And we have distal curve, that is bronchial tape. It is a curve and it is so far designed to enter right or left bronchus. Now we are moving to the indication. There are absolute indication and relative indication. The first point is isolation of each lung to prevent contamination of healthy lung, that is infection and hemorrhage. Second, control of distribution of ventilation to only one lung, bronchial disruption. The third point is unilateral lung lavage. Relative indication. Surgical exposure high priority. The procedure are pneumonectomy, lobectomy, thoracic aortic aneurysm. The second point is surgical exposure low priority. The procedure is esophageal surgery. Now we are moving to the proper insertion technique of double lumen tube. First we have to select an appropriate size tube, that is 35 to 37 French for women and 39 to 41 French for men. After that we have to check the cuff for leak. After checking the leak, we need to position the patient in sniffing position, that is extension in the atlanto-occipital joint and flexion in the cervical spine. After positioning the patient, we need to perform direct laryngoscopy and intubate the larynx with the bronchial curve angle anteriorly. Once the tube enters the vocal cord, for left-sided DLT, rotate 90 degree counterclockwise and advance into the left main bronchus. For right-sided DLT, rotate 90 degree clockwise and advance into the right side bronchus. As shown in the figure, when the tube enters into the vocal cord, we need to rotate respectively counterclockwise or clockwise, and we have to advance into the desired bronchus. After that, first we have to inflate the tracheal cuff, then we have to inflate the bronchial cuff while checking for the resistance and listening to the breath sound. For the position confirmation, we have to use fiber optic bronchoscope to confirm correct placement of the bronchial lumen in the desired bronchus. There are three types of double lumen tube. It is Carlen's double lumen tube, White double lumen tube, Robert Shaw double lumen tube. Carlen's double lumen tube. It is a left-sided double lumen tube and it is developed in 1949. It has a cranial hook that helps secure its placement in its left bronchus. It is used in older technique but less commonly today due to potential airway trauma. Wide double lumen tube. Right-sided versions of Carlin's tube also have a cranial hook helping to position in the right bronchus. Less commonly used due to difficulty in right upper lobe ventilation. Now we are moving to the Robertshaw double lumen tube. This tube does not have any cranial hook, available in left and right sided version, provides better fit compared to Carlin's and wide tube. One of the most commonly used double lumen tube in modern practice. The Robertshaw double lumen tube is primarily used lung isolation and one lung ventilation during thoracic surgery. The tube is designed with wide lumen for reduced airflow resistance and a curved shape to minimize kinking, making it a valuable tool for thoracic anesthesia. Now we are moving to the advantages of double lumen tube. It is easier to position, can be positioned without bronchoscopy, enables independent lung ventilation in ICU. Each lung can be inspected with a bronchoscope. Less time is required to position as compared to endobronchial blockers. Disadvantages of double lumen tube. Problem in proper placement, especially if the tracheal or bronchial anatomy is severely distorted. If patient's condition necessitates mechanical ventilation postoperatively. Changing a DLT to a single lumen endotracheal tube at the end of the surgery can be hazardous. DLTs are manufactured in sizes 28, 35, 37, 39 and 41 French and are often too big for pediatric patients. Now we are moving to the complications of double lumen tube. Airway trauma, that is damage to lip, teeth, vocal cord, trachea or bronchi due to the large size and stiffness of double lumen tube. Difficult intubation. Double lumen tubes are bulkier, hardened to place, especially in patients with difficult airway. Esophageal intubation. Misplacement into the esophagus instead of trachea. Now we are moving to the contraindications. Difficult airway, tracheal or bronchial abnormalities, recent tracheal or bronchial surgery, neck or spine instability. To summarize the topic, double lumen tube enables one lung ventilation during thoracic surgery, allowing selective isolation and ventilation of either lung while the other lung deflate for surgical access. This led to improved surgical precision, reduced risk of complication and better patient outcome. These are the reference. Thank you.